Let's roll with the afternoon. Everybody's got enough sugar in them. I had 2, fair warning. Thought I was talking fast before. Wait till you see what 2 cupcakes does to me. So to kick off this afternoon, we have improving access to palliative care services through the development of a palliative care provider capacity plan. So we're looking for Karma, Leslie, Laura, Denise, and Stacy. Come on up. Thank you. Same flow as this morning. Do your presentation, make eye contact with Claire, become alumni, and same flow as this morning.
So that here. Good afternoon. I'm Laura Vamberlo. I'm a nurse practitioner with our palliative care outreach team, and I service rural Haldimand, Norfolk within the H&HB LHIN. I'd like to introduce Karma Pollock. She's from Hospice Niagara. She's a palliative pain and symptom management consultant. And then I'd like to introduce Dr. Stacy General. She's with the division at McMaster University. And I'd like to introduce Leslie Hurst, or as we call her, Leslie First. She's with the Regional Palliative Care Network. And then Denise Zuwala, who is a very experienced care coordinator with H&HB LHIN, with the palliative care team. So I get the privilege of talking about this, and Leslie gets the privilege of answering all the questions. So our project is called Access and Capacity as Triage the Answer. So we wanted to focus on this project as there's not a standardized approach to triage and care delivery in specialized palliative care teams across our LHIN. We had pockets of geography within our LHIN that were not being served by specialist clinicians from a palliative care standpoint, and we also heard from other specialists that they no longer possess the capacity. Their delivery of care was maxed out. When we started, we had hoped to have the following impact on patients and the team. Following a referral, patients' needs would be identified and triaged based on severity, life expectancy, as well as the risk of the situation resulting in a 911 call or an emergency room visit. Through standardizing the process of triage, the patients would see the right provider at the right time. For providers, they would have an evidence-informed system that would enable them to prioritize patients from an objective perspective and see patients based on their personal competencies. A significant amount of work has already been previously completed on this, and a tool has already been developed from the Gippsland Regional Palliative Care Team in Australia. We've adopted and adapted this tool to our particular purpose. Our theory was patients were seen by specialist teams in 2 ways. First, on a first-come, first-served basis. The referral came in, whoever is available went out to assess the patient. Or 2, when there was a crisis. You often hear teams speaking that wheels are falling off the bus, or putting out fires often. Teams did not have a standardized process for triage, and each member of a team and each teams did this in a different way. By implementing this methodology, we wanted to remove duplication while building processes that were patient-centered and ultimately would result in increased capacity for our teams. This led us to our AIM statement, which is 80% of patients who meet the surprise question criteria will be triaged to the appropriate palliative care specialist by April 2019. In order to better understand more about our project, we used following diagnostic tools, so fishbone diagrams to determine drivers, enablers, and barriers. We developed multiple process maps and used historical specialist team performance data reports. We engaged the HQO team in decision support for our diagnostic journey and found that since we were focusing on qualitative outputs, we needed to use surveys to capture data about utility and preference. It was important for us from a relationship lens to ensure that the providers were heard and engaged earlier on in this process. We did a great deal of active listening to their concerns, which in turn only fostered and further developed relationships and connections across our LHIN. Of noting is that this project did span 3 separate subregions within our LHIN, and our LHIN is a large geographical area. One early finding was that the tool provided a clear sense of urgency for the patient. Many referrals arrive with a reason for referral of pain and symptom management. So there's a significant amount of work done after the fact to determine what exactly does that mean from the patient's need perspective, because that can be something very simple or something very complex. Using a tool like this provided a snapshot visually that if a patient's symptoms had been scored predominantly 3s or higher, so meaning the highest score, we would interpret that it was an urgent need, and whereas if a patient presented after the tool was completed with 0s or 1s, then there would not be an urgent need for an assessment. The tool was inclusive of not only physical issues, but also captured psychosocial and family issues as well. It's also important to note that we utilize the Australian Modified Karnofsky Performance Scale as it is disease agnostic. Using our qualitative survey, we analyzed who was the right person to complete the tool, either at or after the time of referral receipt, how beneficial it was in identifying patients' needs, and did it duplicate or increase workload. Our data showed when people were referring, the tool did help with referral, but that the tool did not help with referral, but it did help to identify urgency. The system barriers and variance in teams did not support determining who the provider would be for the patient, but it did help to demonstrate that when people are referring, what people are referring for and what the patient need is. We learned that schedules and metrics were often big drivers as to who is seeing the patient as opposed to the patient need and urgency. Other barriers we found were IT. Multiple systems in healthcare have created multiple processes and multiple workarounds within teams, so adding another process for certain roles was a barrier. The tool was preferred by those in a provider or coordinator role, associating the tool with role, function, and competency instead of focusing on job title, supports the ongoing use of the tool across multiple teams with different complements of specialized clinicians, as well as within the identification of the appropriate provider to meet the patient need at that time. In addition, by focusing on role function, this helped to identify current capacity and gaps in services that are needed to access or that are needed for our patients across our LHIN. Our next steps will be to run the second PDSA cycle of the tool and further refinement of the tool. Our biggest challenges were many system barriers, such as IT and reporting requirements of the palliative care providers. Example, that each provider needed a certain number as a key performance indicator for their contracts, so those kind of things, schedules, part-time accommodations, etc. Our advice going forward for anybody else starting a QI journey is go big or go home. And that's it. We'd also like to take this opportunity to thank our executive sponsors and thank our HQO advisor, Shauna Cunningham, for all of her support.
Excellent. Thank you. Remember way back when we were all excited about computers and we were really excited to get one? Do you remember that? When it used to be exciting? Yeah. What are you curious about? Go ahead.
I'm interested in this triage process and identifying urgency. So you've described two things. One was functional status and symptom burden. Are there other things that you feel, either a part of your tool that you feel reflect urgency, or the other thing we've thought about a bit, reflect urgency or complexity? Other things that need to be part of that?
It's a good question, and we really based it on three factors. So patient and family, provider, and then the receiving team. So the patient and family, sometimes the patient's fine, and it's the family and the social determinants, so that's one big piece, and we captured that within the tool. The other piece is the primary team as well that's supporting that patient. So they may be fine initially, but as the complexity, stability, or unpredictability of that dynamic within the patient and family changes, they may no longer have the capacity. And then the third factor is the complement and competencies within the team. So it's a fine balance. And when you look at things like, even just the Karnofsky or the PPS, they're looking at things in isolation, and it can change very differently. So we were looking more at trend. And sometimes the reason for referral is just the path of least resistance. So trying to remove some waste, for want of a better word, in terms of what is bogging down the team with those that really need to be seen based on those three factors. So it's a little bit of a sophisticated balance as opposed to generalist and specialist, but more of a dynamic sort of ongoing process. If that answers your question.
Other folks, what are you curious about? Thank you. Yeah, Celine?
Hi, I'm just wondering if there's a time frame in which you do assess the patients based on their urgency. Like, so for the ones that you rate as the most urgent, what's the time frame in which you assess them?
It's on a case by case, so it's purely individual based on patient need. What really we're wanting to address is if you're getting a lot of urgent referrals, what is the driver for that urgent referral? Is it that somebody has just been diagnosed and the situation's, fairly complex and somebody needs to get out? Is it that early ID hasn't occurred? So the data, as we collect from this tool, will also try and identify what the upstream drivers are for some of these late referrals, thus putting out all the fires. So we want it to be much more of a process and less of a crisis-based. But the reason we said 80% is because we know that there are certain variables that will always lead to either late referral or certain circumstances where things just change or there's palliative emergencies. So, it's not a 911 response. We have another pilot going on with that actually. So, but it's, what is the purpose of that team? And if it ends up being a crisis team, a lot of the times teams that have functioned like that don't sustain because it's just too much. They can't support that kind of functioning. So we're looking at that from two angles. But ideally, what we did find was that people are not referring late to this particular team. The time frame was, I think, over 3 weeks in the tool to 3 months. That seemed to be the biggest cohort of when people were referring, which is still late, but at least it's not in the last 2-3 days of life.
Okay, thank you.
But on the tool itself, there is a scoring that there's 4 different levels, and it makes recommendations. If your scores are all 3, you likely have some urgent needs, right? Even if they're psychosocial urgent needs, they're just as important as physical urgent needs, right? So there is recommendations, but again, it is case by case.
There's a guide, yeah.
There's a guide.
Excellent, thank you. As you transition to be alumni. Speaking of transitions between care settings, improving the patient-family experience. Janet, Kelly, Lisa, Corinne, and Cheryl.
Okay. So hello, our team is Janet Elder, Hospice and Team Lead in Windsor and Essex County, Lisa Pilato from Hospice of Windsor and Essex, Kelly Robertson is not able to make it today, but she's from the Erie St. Clair Lynn Home and Community Care. Corinne Primo is here from Windsor Regional Hospital, and then I'm Cheryl Johnston, I'm here from Hospice as well. So our project's about transitions in care, improving access, and definitely improving the patient and family experience. We wanted to focus on this project because we identified that we were receiving referrals too late to allow us to be able to provide the best possible palliative care to patients and families that they so richly deserve. Some people were dying in the home with no support, no social worker, no nursing, nobody there to help. Others were dying within hours of the first palliative care consultation. And in some visits, the physician was going and pronouncing because the patient had died, even hours after the referral was received, and the physician made it within 4 hours. So we definitely knew we needed some improvements here. We reviewed caregiver surveys from hospice and from the LIN, the Voices surveys, to gain the patient and caregiver perspective. One story really struck us. There were concerns regarding discharge to home, with palliative care services supposed to be in place. It was not. It was a horrific week for my husband, with nothing in place. He was very sick, short of breath. Many calls made. He fell through the cracks in the system until hospice notified us a week later. The kit, which is a symptom response kit, was provided, but you could not access it without the community nurse. The nurse had to come. My husband died at 6 a.m. Nobody came to pronounce until 11. Very sad. Hospice and physician nurses were excellent and wonderful once in place. So we really want to impact the patients, families, caregivers by reducing the number of people that die before being seen by a palliative care team, including social work, physicians, nurses, volunteers, services, in our wellness program as well. Increase the number of referrals for PPS of 60% or less. We want to prevent any patient from dying within 72 hours of service if possible. Increase the length of stay for palliative care services, and that's all disciplines. Increase awareness and intake into the wellness programs. Hospice isn't about death only. We want to get those patients earlier on and help them walk through their journey. And most importantly, we want to improve the patient and family experience.
Okay, so our theory was by referring patients to hospice and/or the Lynn Palliative Services earlier in the illness trajectory, it would allow for therapeutic relationships to be developed and appropriate supports to be put in place in the community setting. This would improve patient and family satisfaction while care needs are in a transition period. So this led to our AIM statement. So 80% of patients being discharged home from the inpatient oncology service with a PPS score at or below 60% will be referred to the appropriate community services by October 31st of this year. So our initial data showed when running our first PDSA cycle that the appropriate services were actually being referred from the oncology floor at our discharge rounds. From our unit. So at our discharge rounds, we actually have the hospice liaison nurse, which happens to be Janet, as well as the Lynn service coordinator at the table. So they ensure that those discharged are aligned with the appropriate services leaving the hospital. So we realized as a team that we needed to look further.
So, given what Corinne just said, we knew that our oncology unit was doing an excellent job. So we started to look at some other data. Through the development of a Pareto chart, what we realized that the people who were referring late were our family physicians and our nurse practitioners within our community. And we know that's a real big group to tackle. But before we actually wanted to look at how we could provide education to them, we knew we had to look at our referral form. So at this point in time, we have revised our referral form, and what it allows for is for a professional within our community to refer to any of hospice services. That is now being implemented on 3 units within the hospital, and we're just now in our very early phases of collecting information. But what some of the data seems to be showing right now as I look at the individual forms coming in is that we are getting referrals earlier, and we're getting them from multiple services. So it's just not for palliative end of care. We're seeing referrals come in for education from our nurses and for social work. And this is really important for our hospice because our mission is to support persons with a life-altering diagnosis. It's just not a life-limiting diagnosis. So that's become very important to us. Seeing people earlier and developing that therapeutic relationship will be very important in their journey for living. So we're in our early stages. What we hope to do is, as we get more forms in, we know the form will have to be revised, so we hope to learn, adapt, educate, and inch forward and move on.
So our next steps, we know that the project doesn't end here. We have to really look at the resources that we have and really look at them and make sure that we're using them in the most appropriate manner. We have to continue to educate our physicians and the Lynn care coordinators about our new form and how it can be used. We want to expand our referral form beyond the initial 3 floors that we have been currently piloting the form with. We're going to track the number of ER and hospital visits within the last 30 days and hoping with these changes that will somehow improve. Track the type of services that are being utilized right now. In the past, when people wanted to refer to the other services, there wasn't an actual form to be used. So I think sometimes people weren't getting referred because people didn't know how to refer to us. So we're hoping that that's going to improve things. Development about hospice education on all the services that are available to us. We're going to be presenting to our senior management about all the work that we've been doing. We want to continue to look at the patient and family experience through our surveys and our interviews. We want to include the new referral form on our hospice website so that everybody has access to it. We want to change how we collect data, and we have a better tracking tool as far as looking at the patient experience for the time that they're on service with us. And at the end of the day, we want to make sure that the patient's always at the center of the decisions that we make. Our biggest challenges were our project. It kept changing. When we first went in, we thought that we weren't getting proper referrals from the oncology floor. We recognized that we were wrong there. So the project kept changing with each PDSA that we did. Trying to keep our project within the limits that we were able to do. Our own ambition sometimes got in the way of us. And one big thing was getting the initial physician buy-in. So our advice for anyone doing a quality QI journey is to don't get discouraged. If you don't get immediate results, improvement, just give yourself time. Many conversations need to take place, which in turn will lead to improved stakeholder buy-ins and relationships that will ultimately change the patient experience. We want to continue to engage physicians initially. Collaboration is great. We have a great team here, and I couldn't imagine a better team. Keep the scope manageable, always have patient involvement, and don't make assumptions. So we're hoping through all of this that these are the kind of stories that we're going to hear now instead of. The confirmation of my husband's palliative diagnosis hit our family like a freight train. However, the care team that surrounded us had a way of interacting with my husband in a way that he was still living his life, not dying. And yet in the background, there was access to a very compassionate, talented, and realistic palliative physician that together with the nurse joined the services and care together with impeccable timing and skill so that my husband could live his life to the fullest for the time that he had left at our home in the woods, and enabled we as a family to be just that, a family. For this, we are thankful, and I hope that the detailed feedback that I have given about our experience will help share the future support for other patients in our region. So I want to give special thanks to this team. You guys are awesome. I want to thank Dr. Sherry Bergeron, who was instrumental in helping us to develop our new referral form, to the Ideas Project and OPCM for this wonderful opportunity, and last but not least, Shauna.
Very nice. Thank you. And you know, what's great to hear in your language now is saying things like our theory is, and then we did a PDSA, and I think 5 months ago, you still had to look down at your paper to see what PDSA, what order does that go in, and now it's just part of what you talk about. It's fantastic. What are you curious about, folks? Go ahead, yeah.
So totally appreciate your story of your journey of how where you thought you were going to start isn't exactly where you needed to begin the work. Are you finding nuances that are worth paying attention to as you're moving to the other floors? Are there things that you're noticing that are different with different patient populations or even teams that are barriers, obstacles that you might need to overcome? So, you know, maybe your driver diagram is starting to change a little bit as you work with each team.
So when we decided on which floors that we were going to pilot the forms out of, one of them, of course, was the oncology floor, but the other two floors were the short stay unit as well as the family medicine team on 6. So that's where the bulk of our referrals come from. We're noticing that for the most part right now, it's still our inpatient palliative care physicians who are sending us the referrals, and they're doing a really good job of completing them because they're really good at that. One of the things that we've included on our referral form is whether or not goals of conversations have taken place. So we're still tracking that to see, because of course we're getting that information from our inpatient palliative physicians, but we want to see what it's going to be like just for the hospitalists or the unattached physicians who are making that referral. So we've had a few that have come outside of the palliative physicians, and right now that's been left blank. So we know that we need to kind of start working on that. Another thing that we've added on a referral form is the PPS tool, or the score, and then we actually have included it on the back of the referral form in case somebody isn't accustomed to being able to use it, so we're looking at things like that. Another thing that we've added on our form, just kind of help us prioritize, is whether or not there's young children in the home and whether or not they live alone. So that, along with the PPS, really kind of helps us to prioritize. And if we're seeing those types of things, that kind of tells us that we need to certainly get into the home sooner. So we're hoping that that's going to kind of help what we're trying to aim is, you know, to get in and support our patients and families.
Fantastic work.
Hillary, yeah, oh, sorry. Hillary, go ahead.
Hi, guys. I'm just wondering if your referral form is posted on Quorum for us to look at and steal from.
Steal shamelessly.
They all look to me to do that. I told you if it has a line or a chart, it's me, but I think Janet is going to do it.
Perfect, thank you.
But that's a great question, and I know there are lots of documents posted there, but this is the great learning, right? Make sure that your colleagues have access to that. Please go ahead.
This is such a great segue following our presentation, but what we found was that the referral form, people really didn't want to write a lot. They just wanted, pain and symptom management, get it in. So we found that the triage form took away that lengthy referral form. Is your referral form still have a component of assessment within it as well with that triage, or is it just purely access?
It's just purely the referral form, and it's a one-page form, so we're trying to make it as easy to use as possible. But when we go back to the goals of care, and that's a big part of it, and goals of care conversation, I think that's what many of us have been talking about today, it shouldn't start when they get referred to palliative care. Those conversations need to happen much sooner, so we're hoping that with adding that part, that'll kind of prompt people to start thinking about goals of care and hopefully even developing that comfort level.
Yes, please do post then.
Please, please, please. Excellent. I think we'll transition you to alumni. Early identification of individuals who would benefit from palliative care and long-term care homes. We have Lisa, Michelle, Liz, Kathy, and Steve.
She is. It's the cupcakes. Yeah. Damn that sugar.
Pause while Shauna takes a photo.
Good afternoon. Our team is from the Southwest Lynn, if you're wondering where that is. The largest municipality is the City of London, and it stretches from Lake Erie in the south to Tobermory in the north. Our team lead has been Lisa Penner. She's the one who came up with the idea, who assembled the team, and we want to thank her for the effective leadership that she's thrown throughout the project. When the project started, Lisa was the palliative care lead for the Southwest Lynn. She decided she wanted to become closer to the front lines of palliative care and transitioned into the role of administrator of a municipal long-term care home in Elgin County. Our co-presenter today is Michelle Harris. Michelle also works for the County of Elgin. She is the director who oversees all of the municipal homes in Elgin. Then we have Liz Laird, and she is the Palliative Pain and Symptom Management Consultant for the Palliative Pain and Symptom Management Consultancy Program for the counties of Grey and Bruce. And I'm going to head off your curious question. I have no idea how she fits that on her business card. Unable to be with us today is Kathy Ellis, who is exactly the same title as Liz, except she looks after the counties of Elgin, Oxford, and Middlesex. She had to choose between attending graduation and attending at the birth of a grandchild. I'm fairly confident she's watching the live stream today. Hi, Kathy. My name is Steve Lichty. I'm the CEO of 2 not-for-profit long-term care homes, only one of which participated in the project because the other one is in a different Lynn. But spoiler alert, we're finding that the knowledge gained from the project actually transfers not just between homes, but across Lynn boundaries.
I don't know if I can top that, Steve, but yes. So our project was called Early Implementation of Goals of Care Conversations in Long-Term Care Homes to promote palliative care planning in the Southwest Lynn, a very common theme that we've been hearing this morning, and especially across long-term care. We wanted to focus on this project because we had identified the need to improve end-of-life care planning with residents and their substitute decision makers or family in a very timely manner. When we started, we hoped to have the following impact: that residents would have a documented end-of-life care plan completed by long-term care home staff, which would identify the residents' expressed wishes and their goals of care at end of life. Those of you that work in long-term care will understand why I'm stressing it's the residents' expressed wishes, because quite often it's the family member who says, I'm the POA or I'm the substitute decision maker, and we struggle with that, as do frontline staff. So our theory was that through early conversations with the residents about their wishes and goals of care for palliative and end-of-life stages, we would be able to improve their overall palliative care experience in our long-term care homes. This theory led to our overall aim statement that 90% of residents will have a documented end-of-life care plan reflective of their goals of care by January 30th of 2019. And I'll just turn it over to Lisa.
Michelle's much taller than I am. Okay, so in order to understand more about our project, we needed to jump back to the front line and talk to the people who were providing the palliative care at the front line. We developed a palliative care team that was interdisciplinary in nature, and we engaged that team not only in our project, but our aim statement and our change ideas that we had thought of as this team as well. The team overall was in complete support, and they began working together to develop a resident audit tool. and began the implementation of a PDSA tool. The internal team really led our work. We audited 100 resident charts across 2 different long-term care homes in 2 separate subregions, both Elgin and here in Perth. So you can imagine the length of time that took and the dedication of those frontline team members to spend their time doing that. And the purpose of that was to determine our current state. How are we doing? How are we doing in palliative care? Were we asking any questions? What questions were we asking? We then analyzed that information that we obtained from the audits, which is found in our Pareto chart on our poster. And the audit tool, we're always happy to share any documents that we created. We spent a lot of time during this project creating some tools, and so of course we're very happy to show those. So the formal audit tool was created. We used this information to inform what was needed for training and education. Once we were able to determine how we were doing, we could then say, okay, here's what we need to accomplish and how are we going to educate our frontline team members so that they knew what they needed to do. The information that we obtained from the survey was compiled and used as our baseline. And then we developed and implemented our PDSA tool, identifying 5 questions that we would add to the resident's care plan. Those 5 questions would help providers determine the residents' wishes and their goals of care during palliative care and end-of-life care. At the first care conference, residents have with our team and their family or substitute decision maker. Formal education was provided, and formal education will be provided in November. One of our learnings was the whole process took a lot longer than what we thought. We thought we would already be evaluating, and we're not there yet. So education November 26th and November 30th to our frontline team members on goals of care, advanced care planning, the POA process, and substitute decision makers. And this education will be mandatory for our staff in our long-term care homes. Our test of change is ongoing. Our original data showed the need for our homes to engage residents and their family members early on in conversations about palliative care and their personal wishes and their goals of care. And our next steps are to educate our staff, to build our experts who are going to be competent and confident in having the conversation around goals of care and resident wishes, and to ensure a minimum of 90% of our residents across our homes have a documented end-of-life care plan in place, identifying their individual needs and wishes. From there, we hope to spread to our other 2 county of Elgin homes, and as well as across hopefully the other 5 subregions with the support of our Southwest Local Health Integration Network, and continue further spread. Who knows where it will go. Our biggest challenges, I think we've heard today from many of the groups, were timing. In hindsight, trying to do this type of work over summer months, very challenging, just because people were on holidays and trying to coordinate meetings, etc. And geography, as Steve alluded to, we were spread from Owen Sound to Port Stanley, and that's a big spread. So trying to pull our 5 team members of this team together to do the work. So we leveraged technology and we continued on, and that really helped support our work. And then again, time to develop the tools. So I think when we first started this work, we didn't realize the number of tools that needed to be implemented to keep our work moving forward. I would like to say on behalf of our team, a big thank you. It's been a pleasure working not only with the team behind me here and Health Quality Ontario, but our QI advisor, Shauna Cunningham, has been phenomenal. And a big thank you to the Southwest Lynn and Sue McCutcheon. I know you're watching today for supporting this project. We couldn't have done it without that sponsorship. So thank you. And any questions?
Thank you. Excellent. Be careful what you wish for, spreading across Lynn's. Ooh. Wow. Excellent. Comments, panel. What are you thinking? Oh, Carol, go ahead. Sorry, I'm going to jump over you guys.
Sorry. I just wondered what the 5 questions were that you used to find out the information from your residents.
Yeah, Carol, so Probably we don't have enough time to go through them, but that's another tool that we're happy to share on Quorum out to all of the other LHINs that you can use those questions.
Excellent. Thank you. Paul, go ahead.
Well, you raised the question, you raised the issue of spreading across the LHIN, and some of you are in system-level positions. What are the key steps in doing that? If you think about taking what you've done and spreading it across the LHIN, what are the key steps to doing that?
Yep, so I think it's working in collaboration with the local health integration network to communicate the work that we've done. Our vision in our community will look very different than a vision in Huron or London Middlesex, say, but the overall vision of early identification of those individuals who would benefit from palliative care, certainly, and having those conversations, certainly, that is a vision, I think, that all subregions have. So it's about that continued conversation, sharing our knowledge, gaining from other groups' knowledges as we have today. My brain is just spinning with all the information that's been shared today. So,
and maybe I could just follow, what's important to CEOs of homes in terms of what do they need to hear and know and understand?
Well, I'm relatively new to the healthcare sector, and the one thing that has really struck me is the importance of the end-of-life care that's provided. Like, there's nothing that's more important to the residents and their families. And I think once you see that, and you see the benefits of some of the things that are going into these projects, it's an easy sale.
I'm just going to add about the spreading across LHINs, for example. I think one of the unique positions that long-term care home is in as leaders, potential leaders, is that you have corporations owning homes across, and so they're not bound by one LHIN, but if those particular, like somebody mentioned Extendicare earlier, Revera, they have opportunities, I think, to make bigger changes and put pressures from another angle. So it isn't just the LHIN, it's those corporations that own is another piece, I think.
Other comments or questions? You're letting them off easy. All right, thank you, folks. And now to our very last group, who we should probably clap for before they come up, because they've waited all day and they probably changed their speeches 6 times. So, Integrated Transitional Palliative Care Model in KW4, Nell, Barbara, Anita, Paula, and Jessica.
Big smile.
Shauna and Laura are going into the photography business together.
So, hello, welcome. We're the showstopper for this afternoon. or you can consider us lucky number 13, because that's our last, we're lucky number 13 today. So, I want to introduce our team here. So, I'm Paula Sampaio. I'm one of the patient service managers at the Waterloo Wellington LHIN. I did ask that the team do cartwheels or something since we're the last group, but no one was willing. She can tap. To the right of me is Anita Adams. Anita is our NP, our integrated NP at Grand River Hospital, and also is a point 2 position for our Waterloo Wellington LHIN. We have Jessica Cazares. She's our NP for Waterloo Wellington LHIN as well. Works very closely with our HPC physicians. Barb Blockay, that she's our regional palliative manager. And we have Niall, right over here to my right. And Niall is the director at Grand River and covering a few different floors at this point, but medical is too long to list, but stroke. So if you want to add Niall, I think we got it covered at Grand River. So I just wanted to, first of all, just take a moment, and as we sit here and just acknowledge all the work that went into all of these projects, I feel I just need to acknowledge the incredible work and innovation that went into every project, and the impact that these projects will have on providing seamless care, seamless palliative care in our communities. So I just wanted to say a few words there. As we started our journey as part of our project at Grand River and the LHIN, we started to identify a gap. As most of you have mentioned, and there's common themes, we talk about transitions, we talk about discrepancy in information that our providers receive, discrepancies with our physicians, and what they're receiving. And all of this impacts patient care. Very similarly, our patients are also struggling in receiving the most appropriate information, up-to-date information, and understanding who to call and when. So as part of our work at Waterloo Wellington, we were collecting data from our patients' survey, so Voices survey. And that's how we started our process and the journey that we led into creating the integrated transitional palliative care tool that you can see up above us. It's quite small. But what we started to collect first as part of this project is getting some themes, and there were some comments on the Voices survey from patients' families, identifying the gap and identifying communication gaps between providers, our physician groups, and not sure where they should go. So that's where we started our process in reviewing that data. So we just had some anecdotal data from the survey. From there, we started to build across and trying to identify readmissions to hospital for our palliative patients and starting to collect some data to create our model. We had a lot of conversations with our external providers, both our service provider agencies for nursing, our therapies, PSW, just to better understand what are the gaps that they have in what they receive. Also looking from a hospital perspective, readmission rates. Are we finding that more palliative patients are getting readmission rates within those first 30 days? What does that look like? So we started to do some process mapping and working with our providers, our HPC physicians in primary care, some of our primary care members, and to identify what that gap looked like and what was the volume and what was the impact that was happening across the board. So we started with our process mapping. We got together as a group. So our dynamic team here was meeting quite frequently, weekly, hours at a time. And as I'm sure everybody can well appreciate with the work that went into these projects, it's a lot of information and to narrow down your scope. So we were trying to get a better understanding of what that would look like for us. Because our goal is that every patient would be discharged with a transitional tool or a discharge tool, and that every provider would have a well-rounded understanding of who that MRP is, where they are in their journey, whether it's treatments, what medications they were prescribed. So some of the common threads and themes that we're missing. So we did our driver diagram. We met and engaged with our service providers, our physician group, again, looking at our admission rates. The other piece is then we narrowed our scope down to focusing on patients with a PPS score of 40% or lower as part of this model that would receive this discharge tool as part of our pilot. And the goal is that by March of 2019 that we want to see all patients being discharged from Grand River with a palliative discharge tool. And it's not about the tool, but more about the communication, that integrative plan, care plan that we talk about. Across the board, we're talking about coordinated care plans across all of our regions, and how do we best support each other and have the information needed to provide ideal care. So some of those pieces and measures, as we worked across our community, we've started our pilot September the 24th. Anita's role is very unique. She works as a palliative care consultant through the hospital as an NP, and point two of her role would be going into the community. So she is really an important role within this model as she sees many of these patients. So she's identifying these patients as well as our care coordinators at our LHIN in that criteria of 40% or lower. So, so far, as of September the 24th and to date, we haven't had many patients that are fitting that criteria as well as we thought there would be in the time span that we've had. So we've actually broadened our criteria and opened it up to all palliative patients. We were starting off with our medical floor in oncology, and now we're looking at how do we best self-identify, and our care coordinators are in hospital are the ones that are primarily maybe flagging them over to Anita, as well as the team, the hospice palliative care team at the hospital for consultative model, both Dr. Harlick and Dr. Molman. So our next steps as we proceed, we have developed the tool. We have received some initial feedback on the few patients that have started on this model. Anita will be seeing patients as well in the community. So those patients that may require more intense, urgent support as they're awaiting either an HPC NP or an HPC physician. So, if, you know, in that time and having a warm handoff is part of this process. The other step and goal is really that we are also spreading this across once we complete this model over at Grand River, is we've had a lot of feedback from different hospitals across the board is how can we have the same or similar tool and look at enablers such as our technology. What can we enable into either EMRs, into our CRIS documentation? And I know that across the board, across our system, that is a challenge. So we are continuing to plug away at that, similar with our NPs, having a common EMR system that can be shared. So as we go through our next steps, we've opened up, as I mentioned, our criteria. So I'm sure we're going to start to see further patients coming on to the pilot. The other piece is further engagement with hospital staff, so hospital nursing staff. We understood another gap in this process is having nursing staff a good, well-rounded awareness of palliative patients and the education involved. So with PPS scores and ESAS is where we're starting. The other piece is we've created some evaluation tools. So we have an evaluation tool with our service providers as well as patients. And part of that evaluation would Anita, when she sees patients in the community, she'll be asking those questions. So to the patients, and we've got that pre-approval before we started the model. So some success, again, still a lot of work to come in this model, but really want to acknowledge and very proud of our team, as well as our executive sponsors, and two of which are here, which I'm going to point you out, Karen and Simon, sitting at our table. So we're proud to have them here to support us today. Thank you.
Thank you.
And of course, last but not least, Shauna. We owe you wine.
Oh, wait a minute, there's wine? Thank you, and thank you for being patient and still having all the energy to deliver your great work. Thank you so much. Comments, questions? Oh, Carol's got her hand.
I just wondered how you came up with having the tool used for people with a PPS of 40. That seems a little bit low. Are you just trying to target people at end of life, or?
I will briefly speak to this, but I'll also hand it over to my team. And I think that was just the narrowing of our scope when we try to land on a percentage. We started as part of the pilot, we thought we'd start with 40%. But I'll kind of hand it over as well to our NPs.
So it might be widening after the project, you think, or?
Right, so initially we didn't know how many patients we were going to have as part of the pilot, and so we didn't want it to be terribly overwhelming so that we could run lots of PDSA cycles. But over time, we realized that perhaps that was too narrow, and so we've now opened it up. And again, trying to focus on, usually the patients with lower PPS status are closer to active end of life. And so really encouraging that communication between clinician to clinician for transfer of accountability and care. So that was sort of the focus initially, but we've learned lots since we started this. And so now we've opened it up. So it'll be interesting to see what happens. Yeah.
Oh, sure. Yeah.
So knowing that our numbers were quite low, I actually, at the 11th hour yesterday, I went through and I looked at, okay, in the last month, how many patients have we had in our palliative census? So again, this is not an inpatient setting, but rather I'm the NP working with 2 physician colleagues within a palliative care consultative model. And so and we had 4 criteria that we were using. So the PPS of less than or equal to 40, living in the KW4 subregion of our LHIN, people not returning to the Grand River Regional Cancer Center for follow-up, and as well going to a private residence or a retirement home. So what was interesting, despite us opening up the PPS wide open, there was in the last 2 weeks, there was only one other potential candidate that would have met all of the criteria, right? So PPS of whatever, and then those 3 other criteria. And I've broken that number down as well. So it's interesting. We need to further have a look at really who is the population we can best serve with this model. And then certainly a piece of that, and more specific to me, I suppose, that I'm looking at as the NP going into the community, who can I best benefit by being in their homes within ideally 24, 48 hours of discharge, right? So there's been lots of learning, but there's still lots of work to be done.
Yeah, excellent. Go ahead, yeah.
That was a great presentation, thank you. And one of the limitations of the PPS really is the tool itself, and that's why we have somewhat abandoned that and moved to the Australian modified Karnofsky, which is more applicable to any setting, community, inpatient, and disease agnostic. And we find as well that people look at PPS in a snapshot, so it's just, the trend is the important piece, actually, not the scale. So we abandoned that with ours. But it sounds very similar to what you've identified in terms of using something like that to drive services rather than the complexity, predictability, and stability of the patient, and then the 3 factors of the team. So, I'd be curious to know if in your next cycle you would want anything from us, and likewise we would want something from you in terms of your access point. There's always a caveat to that, but the 2 projects just sound so similar, and we do share a border as well. So we should connect is what I'm thinking as our maybe larger next steps, PDSA version 28 or whatever we're on.
Would be happy
Excellent.
to connect.
Excellent, yeah, excellent. Thank you. Broaden that community. Yeah, go ahead.
I'm just curious about your tool. I can't really see what's on it, but is it a tool that would be suitable to share with the patient? And I was just thinking that in a different setting where we transition patients in survivorship, the patient has a copy of their handover information as well as the provider, and it really helps to empower the patient to know what to expect and what information has been shared with the provider they've been transitioned to.
So, great question. I would say at this point, because our numbers have been low, I can say that I don't believe that our 2 people have received a copy of the tool. But of course, in part, again, taking some of that learning, the informal pieces that we got around caregiver experience, both from the surveys, but also, in personal communications as well. It's certainly something I'm sure that patients and families would be happy to have. So while they often go home with a copy of their discharge summary, even which is very difficult for some people to try to interpret, right? And they'll go home with a patient-friendly medication list, and they may go home with, appointment sheets and various other things. This would be a nice bow to put on that, right? I don't think that there is anything, I don't think there are any components of that tool that should be unfamiliar or unsettling or in other ways, not appropriate for a patient.
Excellent, thank you. Last group to become alumni. So those were 13 pretty amazing presentations. I think I speak on behalf of all the Ideas team. We're always really blown away by what you bring to this final event. So final event, and I should say, as far as the structured part of the learning, not final event, as you've all alluded to in your presentations, the work goes on, right? So we'll let these guys get their photo. Shauna, do her thing. Shauna's just going to bring her children. Well, yeah, it's okay. Yeah, I'm there. Excellent. Thank you so much. And congratulations, everybody. Give yourselves one more round of applause. Congratulations. I'd like to introduce and welcome Michael Sherrard to the podium. Michael's the president and CEO of Cancer Care Ontario and is going to bring us some closing remarks. Did you bring a poster, Michael? Oh.
No, but they're terrific. I'm sorry I couldn't spend all day. I saw the 4 this afternoon, and it's just absolutely terrific, the work that's going on. So thank you all very much. I just want to start with a 1-minute story, and it was triggered by Bob's question, which Steve answered, as what's important to CEOs. And the anecdote goes back to the start of this journey, from my perspective at least, in terms of my really acknowledging the importance of this work in terms of our work at CCO. I went to visit it was probably about 2011, 2012, I went to visit a retirement home just to understand, if I could, more of the issues that face people, older people. And I went to a retirement home. It just happened to be an opportunity I had, and I sat down with the CEO who ran that retirement home and others, and he started to tell me about the palliative care that they were delivering in the retirement home, and when he was very excited, and they'd hired a nurse, and he was showing me graphs of how they reduced people going to the hospital, admissions in hospital, and was telling me about the investments they'd made because they had done it entirely on their own as part of the Setter Retirement Home. And at the end of the conversation, I said, well, why are you doing this? It's costing you money, I presume, and are you getting help? And he said, actually, quite the reverse. We get very little help. There are barriers to it, in fact, to doing this. But he said, the reason I'm doing it is pretty simple. He said, I didn't have a healthcare background, but when I started to take on these retirement homes, I realized exactly what Steve said. This is exactly what our residents want. It's good for business. Good palliative care is good for business. And it really struck me, the sentiment that you got across. This is what people want. And that we, in all of our efforts, to improve services in palliative care across the province is because it's what we all need and what we all want for ourselves and for our families, no matter where we live or our background. It's a very common purpose. And that took me back to really, I think, the leading to today in a recognition in Ontario that we could really strengthen our efforts with respect to palliative care. At CCO, we held a programmatic review in 2012. I'm glad we're at UHN today because they hosted us then. We probably had expenditure restraint back then, and so it's useful to borrow hospital meeting rooms and things like that. And we had a programmatic review which was led by the Cancer Quality Council to try and look at what we were doing in palliative care. And one of the recommendations coming out of that review was, CCO, you've got a pretty narrow focus on the specific issues facing cancer patients in treatment with respect to palliative care. And actually what you're achieving is quite limited in terms of the overall challenge of palliative care in the province. So rather than focus narrowly on the issues of cancer patients in treatment, you need to be part of a broader effort to support palliative care for everyone in the province and whomever would benefit from it. And for us, that led to, I think, a greater collaboration with what was already going on in the province, which was a whole set of partners, grassroots from across the province, led to the Declaration of Partnership, saying essentially the same thing, that we need some common focus, some common effort with bringing partners together to improve palliative care for all of those who would benefit from it at a population level across the province. Those partners came together and presented that case to the government, and the government supported it in the development of the Ontario Palliative Care Network, which brings together CCO, the LHINs, Hospice Palliative Care Ontario, many partners across the province, Health Quality Ontario, around looking at a common plan by which we can look at this at a population level. It was helped by the Auditor General in 2014, who did an audit of palliative care services, value for money audit, palliative care services in the province. The first recommendation out of that audit was, this needs a provincial approach to improving this. Everyone doing their own little bit, including us, on our own, with our own group of stakeholders, our own populations, isn't going to do it. We need to come together and look at solutions for the province. The government supported that. We launched together the Ontario Palliative Care Network, and as part of that, we came together with an action plan, understanding that there were some things that we could help support that were provincial in nature, common standards, the quality standard that HQO led in terms of the standards that we might expect everywhere across the province. But also understanding that the solutions, the innovation that was occurring, the great work that was already occurring, very much needed to be tailored to the situations, the settings, the people of where those services are needed. And that led at the same time to the development of this work, the Ideas project, which enabled that innovation to be fostered across the province. And it had a couple of aims. One was all of the terrific results that you see here today, leading to knowledge and understanding of the things that work, the things that don't work, and how together we can advance this whole area. But you all graduated at the end of this, and that's a very important theme of this as well, that to advance this work provincially and at the local level, we need leaders across the province. We need leaders locally, regionally, and provincially. And you are those leaders. So that graduation, just as you said, doesn't end things here. Actually, it starts things. It means that we need this leadership to continue, we need the work to continue, and we need you to be the agents of that change across the province so that we can see these benefits that are tested, evaluated. We've got good data and information right across the province. And I'm absolutely convinced that we are on a good track for being able to say, I don't know when, in a few years' time, and when we look back, boy, we have a really excellent population-level approach to palliative care that is meeting the needs, the diverse needs of the populations we serve across the province, no matter what people's backgrounds or where they come from. So I really want to thank you for your engagement today, but most of all, I'm looking forward to your continued leadership with all of the partners as we advance this work for the future. So thank you very much.
Thank you, Michael. Thank you for being here to see some of the presentations as well. And, you know, we warned you guys, this is just the beginning, right? So we really look to you as those champions, as Michael said. So thank you for that message. Speaking of looking to you, we have another piece of looking to you that we would like to spend a few minutes with before we close officially today. So I want to welcome Lacey Phillips and Lisa Yee. Lacey and Lisa, it's not easy to say, Lacey and Lisa, work in the Quality Standards branch at HQO. Lacey is the manager of Quality Standards and Strategy, and Lisa works in Quality Standards. And what they're interested in picking your brains a little bit now. So you can turn off a bit about your own projects. We're not, sort of the focus is off your results in your project. What they're curious about, they have some questions about your experience with working with the Quality Standards. And we did a similar debrief at the end of Cohort 13, which some of you know was the Quality Standards related to major depressive disorder, and we got some amazing feedback. So they're really curious to pick your brains on your fresh knowledge about what was it like to work with the Quality Standards. Because as you know, there are how many Quality Standards now? 14 and more to come.
And 2 more today, actually.
2 more today. Okay, there we go. And so your information for them right now is golden. And if folks are still watching on the live cast as well, I would encourage you through your team members, if you have responses to some of the questions that Lacey and Lisa are going to pose, to please through your teams ask them to send them to us as the advisors, and we'll be glad to share those as well. So I'll turn it over to you guys. Yeah.
Hi, everyone. Congratulations to all the graduates. I did have the privilege to stay today to listen to your presentations, and it's been really motivating and inspiring. So I hope you have saved a bit of energy for us, too, to share about your lessons. So I'm a lead in the Quality Standards Program, so I got to work with OPCN directly, very closely with Susan's counterpart, Ahmed Jakda, with our working group to develop the quality standards. So it's really great to see kind of things come full circle and how people are adopting the quality standards. And I'll just let Lacey introduce herself.
We're just going to tag team. So I'm Lacey. I'm a manager in the Quality Standards Program, and I had the pleasure of working with Lisa and the folks at OPCN, our project team, and the working group as well to develop the palliative care quality standards. And so I work really closely with all the teams at Health Quality Ontario to develop the various quality standards that we develop. And so we really want your feedback on if and how you use the quality standards in your projects. So maybe I'll give you a couple of minutes to think about that. And we just have a few opening thoughts or remarks in terms of the purpose of quality standards and the quality standards program. And it's really to guide, support, and facilitate high quality care in order to achieve excellent care for all. And the mandate for the program is actually set forth in the Excellent Care for All Act for us to develop clinical care standards and recommendations. And we really strive to address variation in care across the province using standards. Also to address areas where we see lower performance or gaps between the care currently being delivered and what we know is best practice. And so we take a provincial approach to supporting improvement across the province. And we were very fortunate to work with the Ontario Palliative Care Network to develop the quality standards for palliative care. And so probably the most important aspect of achieving high quality care is the work that you do. So this quality improvement work that you do. And so we really want to ensure that the resources and supports that we produce as part of the quality standards program support you to do that work. And feedback that we receive from you and from individuals across the province on an ongoing basis allows us to constantly be improving the program, because we often affectionately refer to our program as an ongoing PDSA that we're constantly evaluating and improving. And so we just have a few questions for you. Hopefully this can be fairly interactive. Please feel free to share your feedback. But we're really looking to understand what role the quality standards played in your projects. How did you use the quality standards in your projects? So maybe we'll just open it up for discussion. See if anybody, if you use them at all. In particular, we want to know about the indicators in the quality standards, the evidence sources that we point to, if that's helpful in you kind of making a case for implementing the quality standards. Yes, thank you.
So I think I can just share with you with our project. We use the quality standards to introduce our project to our frontline team members, our interdisciplinary team that became our palliative care working group and helped develop all the tools. And so the standards really were needed to align what our vision was of our project. And do you have anything you want to add? No? Okay. So they're, obviously very important. And I think the feedback that I received was that our frontline team members could relate to those standards. And so you'll see in some of our documents that we created that the standards are reflective in there.
That's wonderful to hear. Thank you.
So I think that for the quality standards, it was used as more, this is something that we need to strive to get to, because we know that a lot of people aren't there yet, but it's a concrete document that says this is kind of best practice, it's where we need to go.
Thank you.
Thank you. I think one of the standards themselves in principle are great, but I think also there's a process for implementation, and one document that's perhaps overlooked that people don't realize is the adoption document that goes along with it, and I'm not sure there's been enough to socialize that connection to this standard, which provides some guidance on what you suggest would be an immediate application or long-term, and so that helps frame and strategize people's approach. So if there was anything, I would suggest that maybe you highlight that piece too, because the standards are nice as a framework and an approach to care, but if you really want to use it in a QI process, I think the adoption is actually more valuable than the standard itself.
Another question we had is just whether or not the standards supported you in having discussions about palliative care. One of the hardest things is kind of broaching the topic with patients and families. Just wondering if any of the resources that we produce as part of the package assisted you with that challenge. And I realize that's a yes/no question, so it doesn't necessarily.
So what you're curious about is the use of the standards in some of those other discussions. Is that yes? Okay. Does anybody use them in those discussions? There's a hand way on the far side there.
We used the draft standards when we were developing our application for ideas, and what we found both with the draft and then the subsequent document that got published was, and we come from hospice palliative care community, working on building a residence. It wasn't necessarily new information, but it was put together in a very nice, clear way that helped support when we're talking to other partners, when we're trying to make a case for palliative care. It's just being put together in clear language, and we really appreciate that side of things.
Great, thank you.
So the next question.
I think we
sorry.
have one more.
Yeah. Oh, sorry.
I feel like I'm doing a lot of talking today,
No,
but
that's okay.
outside of the Ideas Project, so we have an Indigenous community, Six Nations, and we linked with that, and we did a session there looking at the quality standards and how that would be implemented from the Indigenous lens and getting feedback from that. Because I think sometimes these documents are out there, and if it's perceived as a Western worldview, it wouldn't necessarily be applicable either. And we had our community, long-term care, and palliative care team together to say, this is really the same patient population we're talking about. And so we went through them and said, what would this mean, and how would this be meaningful, rather than follow it prescriptively within their community, but in a more harmonized approach. So not ideas, but that's one way that we use it.
That's fantastic. Thank you for sharing. Any other comments? Okay. So I think the next question is thinking more about the measurement piece and the indicators. So we heard a lot about it throughout the presentation about some of the challenges, but I guess acknowledging like in the standard, each statement came with specific statements, suggested indicators. And I think there's also the measurement guide, and then there was also a measurement primer that was customized for your group. So I feel like there's a lot of resources there. I'm just curious about how helpful those indicators were. They're suggested for local data collection. How helpful were those indicators? Did you use other indicators instead, and kind of exploring a bit about those challenges?
In looking at those outcome measures, I think that there was certainly a great deal of information there that is very, very useful. Certainly in the context of our Ideas project, we haven't really had the time or the opportunity to really dive into that, that area. However, I think that with continued palliative care work in each of our sectors, I think there could be consideration around using some of those outcome measures and quality improvement plans. Because I think that we are developing outcome measures anyway for these programs, not only in our QUIPs, but family health teams, for example, have a whole separate operational plan with outcome measures. And we also develop outcome measures for palliative care in that document. So I think they'd be very useful when we get to that stage.
Yeah, great. Thank you. I think Danielle.
Can I just ask a follow-up question to that? And my bias is I work with HQO, so I'm also really interested in this discussion. But if you didn't use the indicators in the quality standard as a jumping off point, how did you, or where did your indicators come from?
In our case, their family health teams have a catalog of indicators that is being developed through AFTO. And so there are different documents available for, indicators for primary care programs that we often draw from for that development. So now we have a new set of indicators through the health quality standards for each of these program areas. So they will be very useful, for sure.
So we did use the health quality indicators when we did our initial fishbone diagram and our driver diagram. And I think one of the great things about them is they're practical, they're realistic, and they're the same problems that we've all been experiencing. So being able to address some of those indicators helped, it's the right thing to do for the patient. It's the right thing to do for the healthcare provider to make sure, people are educated, they're receiving access to care, they're receiving timely care, they're dying in the place of their choice. So I think that's where we really saw the best benefit is right at the beginning, and then having to narrow it down from there.
I was just going to say in the Southwest, we also use the indicators. We basically teased them out of the document and then had a list, and they were very realistic and frontline focused for the residents. And we had the experience of going through a capacity planning report where we developed a formal report of capacity. And so I actually went back and looked at our previous year's capacity report, and those indicators completely aligned with the work that had been done for the last 3 years around that capacity report in the Southwest. So they were certainly very valuable.
Thank you. Any other comments?
So just want to see if you have any other suggestions or advice for us on how we can support organizations to use the quality standards. One of the things that we focus on is we look at the statements and we look at what's in the standard and we say, what are the barriers and what can we do from a system perspective to address those barriers? Are there any tools or supports that you would have found helpful? Hillary, go ahead.
Hi, I'm from the Northwest, and I have to say, I was a bit disappointed today that the team from Anishinaabe Health here in Toronto wasn't here to present on their project, because I think they were the only First Nations project in our cohort. And that for our region especially, trying to explain these concepts or apply these types of approaches and use them with First Nations communities and providers and organizations is a major challenge. And so I was curious to see from Anishinaabe Health how they were kind of challenging the process a little bit here and pushing the envelope, I assume, because for us, again, like Leslie said, to take these documents out to First Nations communities and providers, it's almost a no-go to try to explain. It's just, it hasn't incorporated their ways of knowing or their worldview. They ask, well, how were First Nations consulted? What was the consultation process of First Nations, Inuit, and Métis in the development of these documents? So just knowing, I guess, more how those are incorporated would be helpful.
I don't know if this is helpful. There is a First Nation project in Cohort 16 from the Niminmoya community in the Northeast. So we're connected to them through the Northeast and Palliative Care Network and through Joanna Votor, who's like a regional liaison for the FNIMUI communities. So we'll be sharing that once we have more information.
Did you want to add something? That's what you're going to add. Okay, yes, yeah. And Hillary, I have that team, so we'll stay in touch.
there is a team from the Southwest as well who worked on this. I think they were Cohort 12 or 13, but they've recently just posted on Quorum. So certainly connect with Deanna. She'll be quite helpful and very passionate about this work.
Any other general feedback? Oh, yeah, please.
Hi, I'm Jennifer Boucher. I was actually on the Anishinaabe team, so I'm here representing them in a small way. So we can connect later, absolutely. But the one thing from my learning from my partners, so not to speak for them, but to just convey what I learned in the time, and our project is on hold. So I'm hoping that we can continue. Unfortunately, we didn't get to present today on any results. But the piece that I take away, and happy to talk to everyone about this if you reach out, is it's all about relationship building. And that's a theme that ran through every single project here today. It's about how to create relationships, and then the tools you layer on top of that, the structure, the organization, the tools, and then, it's really the relationships and the commitment that comes first. And I'd say that's the first thing, and in any approach, that's how we should be approaching all our engagements, and that's how that's the feedback from our partners as well. But happy to talk further about more specifics with Hillary and others.
Yes, thank you for that. That's great. Others, general feedback. This is your chance, folks.
Or what would you need to sustain your efforts and spread? What do you think would be helpful from that perspective, if anything?
And some of you may have had touches on other quality standards, so feel free. I mean, the advice is great regardless of the standard you're referring to. Yes.
So not for this project, but from Palliative Care Network at Central Westland, we are very much into Healthcare Ontario standards, and we are trying to spread it. We found it had 13 indicators, right? It was hard to ask everyone to work on 13 at a time. So we are choosing one by one. Yeah. So right now we are following 2 early identification. Like, we are not saying not to follow others, but if you have to pick one, we will support extensively for early identification and advanced care planning and goal of care discussion. We are actually doing lots of education about advanced care planning, healthcare consent, advanced care planning, and goal of care discussion in our region. We have done more than 1,000 healthcare providers, I can say. Not just from healthcare providers when I say it's just, but support workers too, like, right? Like mental health support workers, counselors, all those things. So when you said spread, I thought it would be nice if we had got provincial priorities, this rather than we to choose which we want to pick, or asking organization to choose which one they want to pick and work, because it would be hard to work on all 13. So we just had at least 1 or 2, and then we could get provincial support, we can talk about it, we can spread it, and then move on, right? Because bringing change in every aspect of care would not be easy. So that's the approach we are taking at our Palliative Care Network.
Absolutely.
I think one of the limiting factors for, say, some smaller hospices is the ability to even collect the data so that it's not manual. A lot of them don't have the electronic systems in order to collect the measurement and do the evaluations or look at the data afterwards. A lot of it can be manual collection, so that's a limiting factor for many people.
Although we have also had the experience share with us that sometimes manual is easier because they're 100% sure of what they're getting. So it's an interesting polarity, right? Yeah, absolutely. Go ahead.
I'm speaking again, but it's only because I'm the voice of this group, okay. Apparently. But I think, other people are probably thinking it and won't say it, so I generally am the person that usually says these things, and we shouldn't gloss over the fact that we are not really a cohesive healthcare system in Ontario. We are multiple little systems that try and work together and often have workarounds to work together. And so just from our project alone, when you think about the IT component, we have a team that sits in a hospice, and they're from 4 different organizations, and they're all on 4 different electronic platforms. And so to physically send a referral from one platform to the other, they have to get out of their chair, fax it, or put it into a scanner, get back to their chair. So, you know, we came up with a phrase, what's a distraction and what's a barrier? And we tried to sort of ignore the distractions and then be very realistic about the barriers. And I don't think anybody doesn't support the provincial direction and the fact that we do need a provincial and national strategy for palliative care. But the piece that comes up time and time again is the implementation and how to truly work as a system to do everything that you said, Michael, and everything, you know, that's coming out of HSDF. And I just feel that it's a little bit of an elephant in the room, and I do want to say that it is still a barrier, you know, that we have teams, and you can interpret that word team however you want, but there's restrictions with, you know, a lack of one solid, cohesive system from processes, systems, so on and so forth. But I think people do the best they can, and there are still pockets, and so you're trying to retrofit, and you're also trying to build new. And to be honest, it's very uncertain times in healthcare as well. So there are some sensitivities around that. And I mean, we just heard there from Jennifer that, you know, one of those sensitivities has led a team to not be here today, which I think we all do miss as well. So,
Thank you for that.
I just wanted to say that I 100% agree with that, and I think part of our technology and systems not speaking is a huge barrier, and the multiple referral sources and processes across the province. One of the things that I know that it may seem simple to look at a referral form, but one of the things we identified is in the dictations from the physicians, they were referring to hospice, but the referral was going to other places and not to us. So referrals were going to the Lynn Home and Community Care saying hospice referral, but never did hospice get that until the patient or family are calling and saying, we were told hospice is coming, where are you? We need some help. And they're already in distress. They feel the system's already let them down. So even, it may seem like a simplistic thing, but it was a huge gap in our system, just being able to get the referral, even though it was already identified that the patient needed it, and the intention was to send it. So, thank you.
Well, I think we have one more. Yep.
With regards to like implementation and spreading quality standards, evidence-based guidelines and the like, I think that it's great for the administrative and management level, but to spread those to frontline staff, I think you need engagement from frontline staff. So toolkits, learning modules, things like that that are quick and easy for a staff member to review, so they're not reading the 40-page document, which we know probably isn't going to happen. So,
excellent. Thank you very much. And Lacey and Lisa, thank you for coming here today and asking for the feedback. I mean, I think it's a great opportunity. This is a very smart audience, as you've seen, with lots of experience. So thank you for giving them the opportunity to feedback. That was excellent.
Thanks so much, everyone.
Thank you. And so that's it for that date on the calendar called graduation. But you know, at the risk of repeating myself, it's like Hotel California. You can check out, but you can never leave, right? We do not go away. Couple of thank yous, and then I want to talk about your next steps. So thank you to our panelists, to Bob and Angelica and Susan for being here today, for your insightful questions, for sparking us to think about our projects and to share the learning that you have as well. So thank you for being here today. And thank you to all our OPCN colleagues who are here today, and hopefully you got a chance to connect with your regional liaisons. If you didn't today, I'm sure you will shortly after today. They are your local supports, and as Michael said, you're now champions in your area, and these are your partners in that championship run. So I'm sure they'll be in touch, and certainly us as your advisors, you know, we've been honored to be with you to this point in your journey. We've been over the moon with the results that you showed today. Please continue to reach out to us. Please continue to do your work, continue to meet. You heard so many times today how important those meetings are. We're still there for you, so please continue to have that regular opportunity to check in on your work. And please involve us in those meetings. We thank you for that. Share. How many times today? Is that on quorum? Can you put that on quorum? Your posters will be on quorum under the project section on Monday. And they'll all be tagged quality standards too, by the way. So you will also be able to go in and search by quality standards and see what others have learned from using other standards. Because there's lots of knowledge to be shared back and forth as well. But your posters will be up there as of Monday. Join the alumni community of practice. You automatically do after today, but please go in there and have a look around. It's on Quorum. You probably bumped across it a few times when you were looking for your cohort. We have lots of webinars coming up. There's one a month. Lots of opportunities to be involved in those webinars. We tap many of you on the shoulder and say, hey, we're doing a webinar on building relationships, and you did a great job of that in your project. How'd you like to come on our webinar? So beware of emails from Shauna. That's what they're usually about, just warning you. But we have some great webinars coming up in that series as well. And don't forget your randomized coffee trial. They are your neutral foil in this, right? They're the person you can reach out to and say, not working on palliative care anymore, working on something else. What do you do about this? What do you do about that? How's life? How are things going? How's your QI journey for now? So keep in touch with those folks. Make your pledge for Change Day. Or support somebody else's pledge. We heard lots of opportunities for pledges in the room today. Go online to look at the Change Day website. We're probably over 2,100 by now at the end of today. Join somebody else's pledge or make your own. It's a significant way that we can socialize this idea of the power that we have as individuals in the system to really make change. So I encourage you to do that. Thanks to our ideas team, thanks to Claire for organizing what you can imagine is a logistically complex day. So thank you for that, Claire, and we really appreciate all the work that's behind the scenes as well. Safe journeys home. Remember, this is just see you later. This is not goodbye. And good luck in continuing your QI work. Thanks for all your efforts. And your green sheets. If you have not done those, please fold them and just leave them in the center of the table. Thanks, folks.